Absolutely. Hi, everyone. Thank you so much for being here today. My name is Addie Von Zutphen, and I am the Peak Program Coordinator at K-State. So I get to work directly with homes and teams through the Center on Aging at K-State.
Exactly. And Jamie?
I am Jamie Boone. I am the Adult Care Home Quality Program Manager for KDADS. So I work directly with the K-State team and occasionally get to go out there and work with the homes too for the PEAK program.
Awesome. We also have several other members of our team that are employed with us all throughout the year, and then others who join us during our busy time when we're out in homes and evaluating homes. And so I'll just tell you about some of those. Cora's sitting next to me and hiding, but she is our student support. She is a master's student in gerontology, and she does a lot of the communication and organizing of materials, and just our right-hand woman for anything that's needed for the project. And then Jackie Sump is one of our consultants and does a lot of work with the program materials and development and resources and doing one-on-one coaching with teams. And Madison Parker is also on the team, and she is out on maternity leave right now, but she is also one of the program consultants who does education and one-on-one coaching. And then we have service providers that come on and do a lot of traveling with us and working out in the field directly with homes. So that is the makeup of our team. And I will get started in just giving you an overview of what the program is and some of the benefits that we've seen. And then there'll be opportunity to ask questions at the end of this, or if they pop in your head as questions, please do put them in the chat, because we want this to be about what you came here to learn about. And so if we're not covering that, we want to make sure that we answer your questions. So we already met the team a little bit, but we'll talk about how that works, give you a brief history of the program, look at the PEAK timeline and different levels of the program, and then hear from you. So we talked about kind of two different teams. So KDADS, this is a KDADS Medicaid, part of the Medicaid reimbursement program. And so on their side, their role is to oversee the program, apply program incentives to Medicaid reimbursement, and support both the K-State team and homes in the program. And then the K-State Center on Aging handles the administrative functions of the program, facilitates trainings and evaluation of participants and that one-on-one support wherever it's needed and coaching. And then we really help support homes as they navigate the program. So PEAK is pretty unique. I work on the national level with long-term care, caregiving, and person-centered care. And I can tell you for certainty that PEAK is one of the only pay-for-performance nursing home improvement initiatives in the country specific to person-centered care, particularly in the quality improvement space. All of the other programs that are related to person care incentive are self-report by the home only, and they are outcomes driven. So homes get payment when they're done with the work, and they don't get any incentive dollars while they're doing the work. And so PEAK is different in that way, and that we reward homes through the incentive process, through the process of implementation at lower dollar levels that you'll see here in a bit, and when they reach their goals. And when we're talking about complex change that person-centered requires to systems and homes, that's really important. So that sets PEAK apart and our state apart from any other state in the nation. PEAK incentives incents nursing homes to adopt person-centered care through organizational change, and homes receive Medicaid dollars as they continue to implement person-centered care practices. So historically, this program started in 2002, and it was a recognition and education program to support culture change in long-term care and really to recognize homes that were doing innovative things in the way of quality of life and care for elders. And so there were applications, and once applications were submitted, these homes were visited, and then they would receive an award. And so that reached maybe about, on average, about 50 of the 350 nursing homes at that time. And the state said, we want more of this to be happening. And so there was a group of people that really pushed for tying this to incentives. And it was at the same time that pay for performance was starting to pick up. And in 2011 is when this became tied to Medicaid reimbursement. And the initial peak levels were created. So they called it Peak 2.0, from the original Peak Awards and Recognition to the 2.0 version. And then in 2022, the criteria stayed the same, but the program reverted to the original name Peak and focused on quality improvement through person-centered care, and which is a more modernized way of talking about it rather than culture change, and then change the payment structure associated with it, primarily to increase flexibility, allow high-performing homes to progress through the program more quickly. And so I think it's really important to talk about where did the criteria come from, because the criteria, which we'll talk about here in a little bit, really ground operationalizing what person-centered care is. I often use the example with homes when we're just first starting to talk about it is when we say person-centered care, we can all talk about what that means to us, and it's pretty high level generally, and it can mean a lot of things in day-to-day operations. And person-centered care can also be a one-on-one or small group interaction, and the way that that interaction takes place can have person-centered care characteristics, but it also can be at the organization or systems level. And what Peak does is really looks at the organization and systems level to help adapt those systems to support individualized care. So it's really important to have a shared definition across operational practices in order for something like this to work. And so the criteria is the bedrock of that. These criteria were developed by KDADS and stakeholder input, some champions of person-centered care at KDADS, evidence-based research and involving groups like K-State, KU, that other university, other people in this state who, KFMC at the time, groups like that that had access to evidence-based research. And then the state's move to managed care, all of those things coinciding, developed those criteria. So I want to talk a little bit about the big picture view of the domains of Peak that lay out the criteria. So there are 5 domains. I'm going to talk about the 4 primary ones. The 5th domain is really an educational domain that is associated with one of the beginner levels, and I'll talk about that one later. So domain 1 is resident choice, and within that there are 4 core areas. So the goal of resident choice is that residents direct their lives. And so within that, there is food, bathing, sleep, and daily routines. And so within each of these, there are specific practices that help support this goal around food that says residents choose what, when, and where they eat. So an example would be that there is food available to people who live in the nursing home 24/7. It does not necessarily need to be self-serve access depending on the population, but it needs to be readily accessible to residents 24/7. So that would be an example of one of the operational practices incorporated in food. And each of those 4 areas has those. You can see the full picture of this in the guidebook, which is on the Peak website, and we can navigate to that after this presentation. And then domain number 2 is staff empowerment. It's kind of interesting when we're talking about resident-directed care, why we have a whole section on staff empowerment. And it's so essential because those closest to the resident are the people who have interactions that either facilitate or negate a resident being able to live their life the way they want to. So we have to empower the people closest to residents to be able to respond on the spot to what residents are requesting to the best ability possible. And so that's why there's a whole area on staff empowerment. So the goal there is that all staff are empowered to support resident choices and make decisions about their work. And there are 4 areas within here. The first is relationships, and this is about consistent staffing, that the same group of staff work consistently with a small group of residents on a daily basis. Decision-making resident care, these titles are a little hard to imagine, so I'm going to explain it a bit. Resident care is really about the things that residents need to support their requests and decisions that they make, that the staff are equipped to be able to respond. So it'd be things like, how do you handle a situation or respond when a resident makes a decision that's maybe not in their best interest, like a person who has diabetes who wants a big bowl of ice cream. How might you respond to that? Because it's a normal part of life that we each take risks. And even if a resident moves into a nursing home, it's really their life. And as long as it is not endangering other people, even if they're in a nursing home, they have a right to make the choices, even if it may not be in their best interest. So really helping equip teams to know what to do and how to respond in that. Decision-making staff work is where we flip the hierarchy and replace that top-down hierarchy with self-led teams that make decisions about the areas where they work. And then the final area here is career development, where there are systems in place to promote professional development, both vertical advancement within the organization and horizontal. So when we have a really good caregiver who wants to stay a really good caregiver, that there are opportunities for that person to grow in that position without having to go get another license or going back to school. And then the last 2 are home environment and meaningful life. For home environment, the goal is that the built environment is recognized as the resident's home, and resident comfort is honored over staff convenience. So in this area, it really focuses on privacy and personalization and comfort in the resident's room, and that resident spaces are less institutional looking and have a feeling of home. And then meaningful life is all about residents having opportunities to pursue a purposeful life. So having say in decisions that go on in the home, and planning things that go on in the home, and supporting their individuality and what's important to them, pursuing purpose rather than being entertained. So that's that area. So across all 4 of these domains, there are 12 concentration areas, or cores as we call them. And so when I say core, I'm talking about the title like resident bedrooms, resident use space, supporting the human spirit, and so on. Okay, so that's the guts of the program in terms of what, if a home enrolls in the program, that's what they're committing to do, is to work on that criteria, improve quality within their systems and processes and policies that support those goals. So then in terms of levels, this is this is an outline of those. There's the foundational level, levels 1 through 5, and then levels 6 through 8. And we'll talk about these. So in terms of incentives, homes that are really at the very beginning or just starting are at the foundation level. And I'll talk here in a little bit about what that entails, but they get an incentive rate for participating in a year-long series of activities and education to help them prepare for implementing the person-centered care practices. In the evidence-based framework, we call this warming the soil. When you make big organizational changes, you need that time to ready your organization before big implementation so that everybody knows what it is we're going to be working towards and is invested in a plan of how is it going to look here. We know what we want to do, but how is it going to look for us? And so that's what that year is designed for, and they get that incentive for engaging in all those different activities associated with that. Level 1 are homes that are just starting on implementation and have passed 0 to 2 cores, and then you can kind of see how that progression goes all the way up to level 5. So as they pass cores, they start moving up in levels. And then once a home passes all 12 cores and receive an in-person on-site visit by a team of evaluators, and they have passed all 12 cores and practices at 90%, they move to level 6. And then once they're there, they work on sustaining those practices and mentoring other homes, and that's how they receive their incentive. And in all of these different levels, there are checks and balances and accountability to the homes. So there's always verification of the different practices that they are doing or mentoring that they are doing and getting credit for with the levels. I can't see all of you, so I'm relying on text messages or Cora to tell me, I can't hear you. So let's dive a little bit further into the foundation level. Like I said, this is a full year of activities. It includes 4 video conference meetings with other foundation homes that are participating. So there's really a networking component of this and working, or being alongside other people at the same level that you are. There is an in-person mentor home experience where the foundation enrolled home goes on site to one of our mentor homes, and that should say 5 through 6. I missed that one. So they go on site to the mentor home experience and get some education on the criteria itself and see it in action and get connected to somebody in a similar position to them in that home. One of the things that is really critical in the foundation level is that these homes are asked to engage a full team in all of these experiences. So it's not just leadership going and participating in these things or going to the experiences, but they bring a team and include a direct caregiver in that. And that's true of the mentor home experience. So we encourage they bring a team. We do require at least 4 from their team come. And then there's an action plan and leadership training. One of the things we know about organizational change is it requires leadership beyond just positional leaders. It requires leadership skills across a variety of different positions. So we do training on that and on strategically planning the steps that it will take and the tasks that need to be done to change systems from ideas to implementation. So the action plan is a big component of that. So I've listed some of the essential team building activities that are included there, and I've talked about some of those. To successfully pass this level, they need to go through the different experiences, and at the end, they must turn in an action plan that then readies them for that next level. So it flows into the next level of the program. When homes are in levels 1 through 5, that's the work of change. That's the work of this quality improvement and implementing new practices. So each home at level 1 through 5 needs to select 2 to 4 cores and turn in an action plan on those and commit to working on implementation throughout the year. Any cores that they've previously passed are reevaluated for sustainability every 2 years. Because there can be a home that has been really successful with PEAK or in person-centered care practices, and they may have had some massive changes, and some of the practices slide back and they aren't in place anymore. And so it's not a one and done situation. Those need to be evaluated for sustainability over time. And so that's looped into this. You can see some of the resources that are included there for levels 1 through 5. We do lunch and learns on a monthly basis, and that is not restricted just to PEAK homes. Those are open. So if you're interested in participating in those, just reach out to us and we can get you on the list to be notified of when the lunch and learns are happening. They're also on our website in recorded form. And then at level 6 through 8, this is the maintenance and mentoring. So they work to keep those practices in place and kind of ebb and flow as time goes and people come and go. And then they mentor others in person-centered care. And they particularly get more mentoring points when they mentor other PEAK homes, because we really want to see that peers help peers. So sharing their experiences, teaching, allowing to come see and experience things. Those are all important, helping teach the lunch and learns and specific practices and sharing materials. Those are all things that are really embedded in the program. And they get the mentor homes, or these upper level homes, get evaluated annually or biannually depending on the level and where they're at in the process. So that's the program in a nutshell. But I want to talk about, other than the fact that person-centered care improves resident quality of life, it's also good for business. And I want to talk about some of the components of that. So workforce is a big one. Turnover cost for a home that has around 45% turnover and is about a 60-bed community costs around $222,000, okay? So when we think of turnover, whatever the position is, that turnover cost is about 33% of their annual wages. So that's how that number was calculated, and it was based on a long-term care accounting firm's metrics for this. And so if you reduce your turnover in your organization, if you had about 60 beds in the associated workforce with that, if you reduce turnover by just 15%, you'd save about $75,000. And what we know from homes that have worked through the PEAK program and started at lower levels and advanced to upper levels is that they reduced turnover during that process. They retained more of their team. And so with investment in workforce, you have cost savings. Then so that's a cost lever, right? Now, in terms of revenue generation lever, we think about census, and 15% increase in average census for some of our case studies with our homes increased. There was a 22% revenue increase per year in homes that had a 15% increase in census. That is an average revenue generation annually of $574,000. So the other piece that we heard anecdotally from several homes is that they were in communities where they weren't the preferred provider for the hospital, so they didn't get just the normal inquiry types of calls from the hospital because they already had preferred providers that they were bringing in for that. And all of their census generation was all from word of mouth, from people that had good experiences, that passed it on to other people and said, you really need to go check this place out. And so that's a big deal. And then in terms of quality and compliance, through research of the PEAK program, we found that there was a 42% reduction in depressive symptoms, major depressive symptoms in those upper level homes. There was a 34% decline in catheter use in those upper level homes versus homes not participating. And there was a 38% fewer pressure ulcers among low risk residents at those upper level homes. So in terms of quality measures and quality indicators, it's a big deal. And resident satisfaction, when we think of the resident satisfaction interviews that were done in the state of Kansas, we saw an increase in satisfaction among residents in homes in those upper level homes of the PEAK program. And not surprisingly, one of the biggest ones that changes faster, even in homes that aren't at the upper level, is food, satisfaction with food. So even at the lower levels of PEAK, there were increases in satisfaction with food, even earlier in the program. So if homes want to enroll, the big push right now is enrollment closes April 30th. And so there's still opportunity for homes that aren't enrolled to get enrolled. And they just go to our website and there's a button there that says enroll now, and you can scan this QR code as well. So that is the end of that. I'm going to leave this screen up for just a minute, but open it up for questions. Are you keeping track of the chat? Yeah, I have it open. Awesome. Okay, so I need to stop share. Stop share for a minute. Why does it still say that? I changed it. Okay, so we have a question in the chat that says, is this available to NFMH as well, or just SNF? This is available for nursing facilities for mental health. And we actually have criteria in a couple of areas that have been adapted just for nursing facilities for mental health. A couple of the areas just as a contextual, so you can understand which criteria would be different. The relationships or consistent staffing looks a little different because staffing is usually a little slimmer in nursing facilities for mental health. So the focus there is more on knowing personalized, individualized, person-centered care plans, and that there's specific training on that when staff are hired. And then in the risk area or decision-making resident care, there's different criteria related to that. But those are the two big ones that look different for NFMH homes. Would it be possible to have the recording or the slide deck sent to us to share with others on our team? We would love to do that. We can get that to Jamie to send out to this group. Awesome. While we're waiting to see if there are other questions, I did want to show you the website. And it is housed on the K-State webpage, but it's linked through KDADS. So it all goes here, and you can see the Enroll Now button. It's here. And this is where all of our resources are. We're getting ready to wrap up the 25-26 fiscal year and move into the new year. That's why there's opportunity for enrollment, but the guidebook is really the heart and soul of where you can find all the ins and outs of the program details. It is a PDF and it's quite long, but it's pretty easy to navigate. So I'll kind of show you that. So this has all of the nitty-gritty of the program, but it also has the full criteria. So I'll just jump to food. So this is a table of contents and it'll jump you right to each of these sections, and it explains out each of those and has further guidance on each of these areas. So you can peruse those things, and the mouse decided to quit working. There we go. And then if you hit the house button, it'll take you back to the table of contents. And you can explore the others. This is where you can also see that there is a special criteria for the NFMH homes. So you would just go directly to that one if you're interested in seeing those specifics. The other thing that is on the website are listing of all the peak homes. And what I would say about this list is this is current for the year. And when you look at levels 6, 7, and 8, you can be pretty sure that, well, you can be sure that the home has met all 12 core areas. And there's direct contact information for those. When you look at the lower levels, remember that they're in process of implementing. So they, are still learning or still implementing, or maybe they are at level 2, but right now they're having trouble and they're at, they're stalling out at that level. So it's helpful to know a little bit about each of the levels. So when you're looking at that list, you can look at it through the appropriate context. Okay. So not every home that is enrolled in the program is going to have that really high level of person-centered care practice implementation, but they are invested in working in it. And then there is the resources as well. And these are where you can find the Lunch and Learn videos, and there are different resources for the homes that we point them to. And these are freely and widely acceptable to anybody, and can be shared widely. Okay. Any other questions or things that others want to add on the team? Yeah, I can put the link in the chat.
I'm sorry, Lacey, did you just ask me something?
No.
Okay, good. I've got caught in a call. I'm sorry.
So Sherry is saying, let everybody know about the annual conference. Absolutely. So what are we on this year? This will be our fourth or fifth annual person-centered care conference that is hosted in Manhattan here at the university. And it is a general person-centered care conference. It's not exclusive to homes in Peak. Anybody in any type of caregiving setting can come, but it is a full day of person-centered care education around all the different topics and practices associated with person-centered care. And so we're always looking to get the word out about that and get people to attend, but also looking for potential speakers for that or volunteers that would like to help with it. So that is happening in October. It happens annually in October. And the official date this year, I have to look up so I don't tell you wrong. But somebody's going to figure it out before I get to it. But it is the 23rd of October this year. Yeah. The flyer and registration is not available right now, but it will be coming out and we will share it widely. And it will also be on our Peak website. There is a link that's specific for the Person-Centered Care Conference. And so KDADS will send it out through any channels that they can to spread it widely. But we usually do the registration and full flyer with all of the details in late August for the October conference. And what's really fun about that is, I didn't mention this, but Peak has an advisory board, and Luann is one of our members on the advisory board. But it's made up of providers and different stakeholders who champion person-centered care or want to have impact on this program and say on the program to give feedback. And that group is heavily involved in planning for the Person-Centered Care Conference and have been invaluable with that. So that's another avenue or way you can get involved in Peak if you can't directly be involved in it. For one reason or another, is you could potentially be a part of the advisory group. There's an application process to be a part of that. And it's a rolling process. Right now we're full on membership, but that is always evolving. So you can put your interest out there if that's something that attracts you.
Hey, Lacey,
Yeah.
is there something special about this upcoming peak year?
Oh, yeah. There is. This is our 25th anniversary of Peak. So we're going to have a big to-do about it at the conference. So we're landing on the official. Did you guys land on the? I wasn't at the last advisory group meeting. So did you land on the official theme?
We did. And if I get the wording wrong, please, Addie or someone else, make sure that I got it right. I don't have it directly in front of me, but shining bright at 25, illuminating something care.
The future of care.
The future of care. Thank you, Addie. I knew you'd have it. Shining and silver. Silver. We've got that color going for us because it's our silver anniversary.
It's pretty cool that it's been around 25 years. It's pretty cool. And one thing I will say is we can always look at where we're at and say we have so much work to do. And that's true. We have so much work to do to improve quality because that's just the nature of this when you work with people. But we've had the opportunity, and I'll just mention Addie's name here. We've had an opportunity to work at a national level with another project related to person-centered care planning and been in nursing homes in other states to do some targeted research and education with them. And it is very clear that Kansas is just at a whole different level with the way that we're able to talk about person-centered care, systems that are in place for person-centered care. We are well ahead of the game on that. What would you say, Addie?
Absolutely. It was night and day, really. Visiting, we were in another state, and while they're doing wonderful things, it's almost like their language isn't even developed to the way or kind of to the level that I can walk into almost any nursing home in Kansas and talk about person-centered care or kind of those themes, but the language isn't even quite there in some places. So it's really cool to think that Kansas has such an innovative program that has KDADs behind us. It's not just, us believing in this. It's really, kind of it's broad. It's bigger than just, a peak program, but it's something that everyone believes in. So I think that's really special and very evident as far as how great it is to be in Kansas.
I think that was also something that was pretty special about working on that national project, is that when you get together with a group of people from all over, there's definitely pockets where you learn really awesome things that you didn't know about already. But one of the things we found is around the area of care planning and learning about resident preferences all the way to implementing it into care, that the tools that were developed here in Kansas by our peak homes, other places didn't even have anything to use for some of these things. And so we brought tools from our work here in Kansas and partnering with homes here in Kansas to bring to the national level, because they just don't exist. And so that's pretty cool. We're filling gaps on a national level that are needed. So it's pretty cool. So we're done with our formal presentation, and we are going to stay on until 1 o'clock. So if you want to stay and listen in on any questions that come up, please do so. But you can pop off if you got everything answered that you wanted answered. We will redo the presentation, at 12-ish? There's a question in the chat that said, is there an application or other document to complete to show interest in participating in the program? And yes, there's a link in the chat that if you go to that, there's an enroll now button, and that's what you would fill out to show your interest in participating. And it'll give you instructions on that, and it'll go right to Cora, who's sitting next to me, and she can connect with you and let you know that she got your application and answer any specific questions that you have. We'd love for you to participate.
So far this year, as far as homes starting the foundation next year, we have 30 homes signed up to start at the foundation level with us next year. So very, very cool. I don't know if it feels like a record to me because this is my first go around. So it's a record in my brain, but a really big deal that 30 homes, we'll have 30 new homes on board.
That's awesome. So there's a question in the chat about examples of innovative person-centered practices that we've seen this year. And I have so many, but I like to share this one because I think it's pretty cool. It didn't actually happen this year, but I just think this group would appreciate it. But one home, they were working on daily routines, supporting daily routines. And in this core area, the goal is to start gathering information about residents before they even move in. And then it goes all the way through that process to care planning, involving direct caregivers and care plans. And this home really embraced involving residents in every aspect of what they're doing with Peak. And so they developed this really great move-in tool that gathered information about residents' life story and preferences and so forth. It's called All About Me Form. And so that is the first thing they do, even if they're coming from the hospital, is they call a family member or they talk to the resident. And on that, they find out some of the residents like preferred toiletry items, like their favorite soaps or shampoos or things like that. They find out their favorite snack, and they find out their comfort meal. Like, what's a meal that you know, that is just when you're not feeling good or whatever, it's like your favorite meal or your comfort meal. And so that was happening. And then the residents had the idea that they wanted to form a welcome committee, because when somebody first moves in, it's kind of a transition time for them. They don't know much about the home. They don't know anybody, generally speaking. And so they formed a welcome committee that included residents, and the residents, depending on who the new resident is, would match up and make sure that that person had a resident contact as soon as they moved in, to be able to ask questions and to sit with the first couple meals, just so that they could get, familiar with things. And that same welcome committee that included staff and the residents decided they would, for every move-in, they would have a welcome basket that included not generic things, not like I'm advertising the home and how great we are and we have our swag in it. Like, it had in it the stuff that the residents said they liked. So it would have their favorite snack in it, it'd have their favorite toiletries and a few other little items that they thought might be helpful when you move in. And then within the first 24 hours, the kitchen staff made it a point to make their comfort meal just for them in their first 24 hours. Like, that's big. That's individualized care. And that was something that that when you talked to one of the new residents there, they were just like, I didn't know what to think. I thought, did they have a video camera that said, that told them who I was? Like, it was my stuff there. And it made all the difference to that new resident. So that's my story, but I want to pass it on and have somebody else on the team share a story. What's one of your faves?
My absolute favorite from when I was on a visit, and this was a few years back because this is the first time that I worked with the program, was the trampoline story. We were in a home, and it's a question about asking full team what they've done, risky decisions with why something risky that the residents wanted, and how they help them with that. And it was really, really a cool experience because the entire team laughed and they looked at each other and they all knew what they were going to say before they said it. And it was, they wanted a trampoline. And how are they going to do a trampoline? How are they going to do that safely? How are they going to meet this risk at the same time of, how do we do everything? And they did it. And they did it beautifully. I believe it was, correct me if I'm wrong, Lacey, it's been a few years. It was just a smaller trampoline with 5 handles, but it made the residents happy. The residents were also safe. And it was just a really, really beautiful story. Like, everyone around that table had fun figuring out how they were going to do this, doing the research. And it was just, yeah, the laughter and the smiles in that meeting were just beautiful. That is one of my favorites.
I always enjoy part of our evaluation process is talking to direct caregivers one-on-one for the full on-site visits. And I always really appreciate there are some questions that, person-centered care is so ingrained and it's like second nature. They don't really think about it. So you can't, sometimes we ask questions that are, some people may struggle with, some people may not. But the best responses are when you ask a question and they look at you like, of course we do that. Like that's who we are. And it's just, you can just tell there's a sense of the person-centered care is so ingrained at from every aspect and all the folks in the home and residents too, looking at you like, what do you mean? Of course they don't wake me up. Like that's shocking to them. So it's really cool to see um, when person-centered care is just really ingrained in the culture in the home.
Thanks, Abby. I see
Favorite,
JC's on you. Go ahead. JC, do you have any favorites? She might not.
Sorry, I've been in and out. I've been on the phone with Jackie.
Oh,
Um,
sorry.
are we talking about favorite person-centered care stories?
Yes.
I don't think I have like any like grand gestures, but you can tell like when you walk into a home that is person-centered, to the core, there's just this feeling of home and just a warm and welcoming environment, even as like a visitor. That you can tell that the home really just operates like a family environment. Um, so it's just more of like the smaller, like daily things where you can see people are having to can have their continued um way of life that they had prior to moving in or prior to, aging. They're just continuing on living their life however they did. So yeah, just the little things.
Awesome. Some of the stories don't come from being out in the homes or doing evaluations. They come from the process of talking to teams as they're working through this, because this is hard work when you're truly changing practices. It's kind of like the example that I share, that what we're asking for in Peak is not changing the name of a bib to clothing protector. It's getting rid of the clothing protector and offering other alternatives and care planning just for those situations where people might need that. So we are literally changing practices, and that's hard work, right? And so these teams pour their heart and souls into it. And there's one team that was working through things, and they developed work groups around the different cores they were working on. And there was a work group on bathing, and the bathing group had the bath aide that was currently the bath aide. They eliminated the bath aide position, but that she'd been the original bath aide, some nurses, and they were struggling to have another person on the team because they also had other work groups, but the bathing areas needed some maintenance work done to them. So they strategically recruited the maintenance guy to be on that bath team because they thought maybe they could get some of the work done if he was on the team, which I think is kind of funny and smart. But what was really interesting about that team is when I thought about what questions do we need to ask residents about their bathing habits and stuff, it was the maintenance guy who went around interviewing the residents to find out like what questions they should ask and things, and really got vested in developing the interview tool. And when it came time to evaluate, he was the one that like really took the lead on that group and got excited about it. And the work got done in the bathing areas too. But surprised that sometimes the roles we think because of our position, people should be in a work group. It's not, people bring other skills to the table. And sometimes by engaging in that work, they get outlets that make their work more fulfilling to them, and more purposeful. And that kind of goes with some of that retention piece. In that same group, it's kind of funny, it's the same group, but there was a CMA on that group, and she had been the bath aide before, not the current bath aide, but that was part of why she was on the group. But she was really talented with Excel, like the program Excel. And in her job, she didn't have a reason to use it, but she just in her private life had gotten really good at it. So she's like, "Ooh, I can make a cool tool for this." And so her role was to create the tool that they were tracking a lot of this with, and added some bells and whistles to it that she's like, "Oh, I'll teach you how to do this, and I'll teach you how to do this." And I really let her shine too, it unexpectedly. So I think those are some of the stories that just make me excited about it in terms of empowerment and the team dynamics and stuff.
Hey, Lacey, how many homes do we currently have enrolled? Do you know off the top of your head?
I can give you an estimate. I don't know exactly, but it's around 95 right now. And that number kind of ebbs and flows. I would say that I think this is a good point in the conversation to say that that this program is amazing. And when you really, when a home really commits to it and works the process, because it does involve actual change, it's amazing, but it's also hard work, right? And so sometimes homes get enrolled because it's really good incentive dollars, right? To get, but they don't invest in really committing to the practices, and that can be frustrating, right? If you're enrolling in something, you aren't really working towards it, and then you're not seeing success of advancing, that can be hard. And so some homes, you know, come in and out of the program because of that, I would say. And it's always open and available when homes are ready for it, but there is accountability to it, and there are actual metrics. And so because of that, it's not just an enroll and get money. It also has to be associated with work, and that can be challenging, right? Sometimes. And so you see an ebb and flow of participation because of that.
Based on that, what you just said, is there a restriction on how many times they can enroll? Or let's say like they've enrolled 10 to 15 times, is that considered acceptable and fine?
So, kind of a yes and no, it depends sort of situation. So a home that is getting an incentive, there are requirements for them to continue getting the incentive. So if they're in the foundation home, they enroll, but they don't participate, they're going to get dropped from the program for lack of participation. They have to set out until the next enrollment period, and then they can enroll again. Homes that are in the like levels 1 through 5, which is where we see more of this. When you get to the upper levels, homes are pretty committed to it. And so you don't see as much of this, okay? But in levels 1 through 5, if they self-report not passing multiple times, then they have to be dropped from the program and set out for a year, and then they can go back in. But it's because, part of the program is that you are committing to the work and getting evaluated and getting that feedback. And so we track all that information, and it's when they're making a choice not to participate or follow through with something when they get dropped or need to sit out of the program. It's not something that we say, arbitrarily you have to sit out, but if they aren't doing those accountability pieces, then they sit out.
That makes perfect and great sense. Thank you so much.
Yep.
So this past evaluation season, we did have a couple of really neat quotes from. I would like to share one that came from a direct care staff and one that came from a resident, if you don't mind, Lacey. So I'm going to start with the direct care staff. Um, I was interviewing the direct care staff as I was helping the Peak team on the evaluation site. And I asked the direct care staff on a daily basis, what duties do you perform besides direct caregiving? And typically we're going to hear, I help with laundry or cooking or, things like that. But without even hesitation, this person's response was to be their family. They're the only family they have. Sisters don't have kids, And it was just like, for this person, it was a duty and a privilege. They were very, very genuine, beautiful, sweet person. It was all about being a family. And that was part of it. I think it's a very neat little way that our caregivers are thinking. And then from a resident this year, when I walked into a home, he asked, is anyone here from the state? And of course I had to say, well, yes, sir, I am. And he said, Miss, and I'm going to leave out her name, is making things better around here. You just really need to know that. So he was specifically looking for someone from the state to report that the administrator of that home, who we were talking to that day for Pete, had been working really hard on making things better in the home. And the minute he saw us, he just wheeled right up to us to tell us all about it. And it was really nice.
Jamie's really good about keeping a running list of great and wonderful things that people say while we're in homes. And she was so gracious with her time this season and went on every full site visit. So she has quite a few quotes and some nice remarks from out on the ground reporting from Jamie.
That made me remember this. Yeah. There we go. Quotes. Okay. You want me to do the initial presentation again for people who missed it the first time? Okay. So for people who've already heard the presentation that started at 11, you may or may not want to listen to it again. You're sure welcome to stay, but it will be the exact same content. But if you missed the initial presentation, we will do that again. Okay. Do you guys see the slides up there? Okay.
Still the quotes.
The quotes, okay. Try again. I saw the right one, but I didn't share it with you. Here we go. That's why you ask. I would have gotten on a roll and you'd have been like, what happening? So We're just going to go through the full Peak team and how we work with KDADs. We're going to talk about the history of the program, look at the different Peak timelines and more about the program, and then open it up for questions again. So Peak team. My name is Lacey Cornelison. I'm the director of the Center on Aging at K-State, and I'm one of the PIs for the Peak program. And we have Addie Van Zutphen on the call. Do you want to introduce yourself, Addie?
Hello, I'm Addie Von Zutphen. I am the program coordinator for Peak through K-State. Before this role, I was also part of our contracted evaluation team that we use during the busier seasons. And so this is actually my 8th year being involved in the Peak program. So very excited about this role.
Yes. And Jamie, do you want to introduce yourself?
I am Jamie Boone. I am the Adult Care Home Quality Program Manager for KDAD. So Peak is one of my 2 programs.
Thank you. And then here with me today, you cannot see them right now, sitting next to me running the chat is Cora Malone. She's a gerontology student and also on track to be a long-term care administrator. And Haley, who went out on Peak visits this year, she's a student that got involved because she was interested in working with older adults and just the program itself. And so she went out and did resident interviews and took notes for us on the evaluation calls. And then we have JC, I think, is on the call. She is one of our program consultants and was the Peak lead for a while as well. And then she's a mama now, so she's stepped back a little from that role. And then we have Jackie Sump, who has been a part of Peak for quite some time. She really works on helping develop education and resources for homes, consulting and one-on-one coaching with teams, wealth of knowledge and information. And then we have Madison Parker, who is another consultant. She's on maternity leave right now, but will be back in May. And then we have service providers who come on just during evaluation time to help with the load of work that comes there and going out and doing the site visits. So that's the team, but the screen that you see now just kind of talks about what KDADS does and what K-State does. So KDADS really oversees the Peak program and applies the program incentives to the Medicaid reimbursement and supports both K-State and homes in the program. And then our K-State team handles the administrative functions of the program and facilitates the trainings and evaluation of participants. And we support homes as they navigate the program, as they have questions or need to troubleshoot things. We're here to do that. So one of the really unique things about Peak is that it's one of the very few nursing home improvement initiatives in the country specific to person-centered care. And it is the only one that has external evaluations of homes. Most of the other programs are self-report, and many of the other incentive programs, whether person-centered care or otherwise, are outcomes driven, so you don't get incentive payments unless you produce an outcome. And that is different in Peak in that there are escalating incentives. So you definitely get more money with outcomes, but you also get lesser per diem by engaging in the process of change, learning about and the process of change, which is different. Incidentally, that allows homes to include some of those inputs and investments on their cost reports as they work through those things and let the cost report reflect those things. And so I think that's really what helps this program stand out from others. So if you have increased training costs for the year, increased staff time for the year while doing that investment in learning, those things are reflected on a cost report, which impact your reimbursement incentives. So that's a really important thing to think about. So I've covered the other two things. Historically, Peak started out as a recognition and education program to really just encourage innovation and highlight innovation in the state around culture change. Incidentally, K-State at that time was writing the Peak modules, which are kind of the first literature out there on culture change that wasn't proprietary in nature, so to speak. And so, but then in 2011, it shifted to Peak 2.0 and tied the program to Medicaid pay for performance. And then the other change that has happened since then is just an update to the program in terms of going back to the original Peak and shifting it to really focusing on quality improvement through person-centered care and changing the payment structure with it to more, it has more rapidly escalating per diems rates and increased flexibility, and it allows high performing homes to move through a little bit more quickly. So the Peak criteria is really the heart and soul of the program. It's how we operationalize what person-centered care is, because when you tie it to money, it's important that you have specific goals or metrics that you're aiming to achieve. So when we say person-centered care, that can mean a lot of different things, and the way it looks in my brain might look different than what's in your brain. And so really operationalizing practices and evidences of person-centered care was important in that initial 2011 introduction of the program. And so KDADS and developed the criteria in conjunction with a big stakeholder group and input. There was a good group of champions of person-centered care at KDADS that really helped drive this. The criteria were really based on evidence-based research, really looking at what's out there that has driven high quality around person-centered care. What are the hallmarks of this that we're seeing across groups that are doing it well? And that's what created the basis for the criteria. And then the state moved to managed care. Those things came together for that shift to what Peak is now. So the criteria itself, I'm seeing stuff in the chat, so I'm just gonna check here. Okay. Oh. Yeah. Thank you, Jamie. So Peak has 4 domains and then 12 core areas within those domains. And so when a home has fully implemented person-centered care, they have covered all of these domains and all of these core areas. So the upper level homes in the program have tackled things across all these different areas. So resident choice is the first domain area, and it's about residents directing their lives. And then under that, there are 4 core areas of practice: food, bathing, sleep, and daily routines. And so a home that is enrolled in Peak that would select food to work on, they're committing to working towards residents choosing what, when, and where they eat. And then within that, there are several practices that are looked at, like having access to food 24/7. And the guidebook gives some additional guidance related to what that can look like and best practices and so forth. There's also audit tools within our resources where homes can audit their own practices to see kind of a similar picture that we do when we are evaluating homes. There's suggested interview questions for residents where appropriate. There's questions to ask the team. There are observations to make within those audits so they can see where are we at with this. And then the second domain is staff empowerment, This one may seem counterintuitive when you think of person-centered care because it's really about the residents, right? But this is really about equipping staff across all levels of the organization to be empowered to respond to residents when they make decisions. And so the goal here is that all staff are empowered to support resident choices and make decisions about their work. And so this area is about relationships, which is consistent staffing. Decision-making, resident care is providing education and access to things that help them respond to residents on the spot rather than having to take everything up a chain of command. So educating on supporting risk and mitigating risk and equipping team members, right, that are closest to the residents with how do we do that? Because risk is a normal part of life. If our choice is not endangering other people, it's really our choice to make. And even those who have dementia at varying levels, in concert with their families, if they're continuing to make a choice that is consistently happening on a regular basis, it's not our job to police those sorts of things. It's to mitigate risk and support them in who they are. And so that's what that area is all about. Staff work is about shifting that traditional hierarchy to a chain of command to self-led teams that make decisions that affect the work closest to them. And then career development is promoting professional development across all levels of the organization. And that would include things like vertical advancement for people who want to get further training or licenses or degrees. And also that horizontal development where we have somebody who's really good at their job and wants to stay doing being really good at that job, but they want to grow within that position. So having opportunities at both sides. Incidentally, a lot of those things are linked to workforce development and retaining our teams. So when we're talking about workforce crisis, such an important and valuable one to think about. And then the last two domains are home environment and meaningful life. The home environment is really about the built environment being recognized as the resident's home and comfort is honored over staff convenience. The way I like to talk to people about it is that you kind of shift your mindset from residents live where I work to we work where residents live because they're there 24/7. So really thinking about privacy and personalization and comfort and that the resident spaces are less institutional in nature. And JC was giving that example earlier that a lot of times when you go into a really person-centered home, it feels different, it hits different, and this is kind of part of the essence of that. A lot of people talk about person-centered care environmentally being unachievable, that it costs a lot of money to redo a building, that sort of thing. And that's what I love about this is that there's really only one thing in here that might cost money, and that's removal of the nurses station. There's a lot of solutions, and we actually have a designer on our team who's a professor here at K-State that has helped homes problem solve that within regulatory compliance. She is actually on the national facility guidance that creates the guidelines for nursing homes. And so we've got it in there. She knows the ins and outs of it, which is fantastic. So she's available for consulting on that. And then meaningful life is really about residents having those opportunities to pursue purposeful life. And in this one, it's really about being able to continue being a part of the community if that's what somebody wants to do, and supporting that, as well as making decisions about the community within the nursing home, and then supporting things that give them meaning and purpose. So those are the areas across these 4 domains. There are 12 core practices, and by the time the home gets to the upper levels of the program, I didn't mean to make those emoticons. I'm sorry. I talk with my hands. So they would have past practices across all of these. So these are all of the program levels. So you start with a foundation and go through level 8 if you go all the way through the program from start to finish. There is opportunity to bypass some of these earlier levels if your home, really assesses where you're at and thinks, hey, we're doing a lot of this. We work one-on-one with homes to see maybe you could be assessed to come in at a higher level. But we do that on a one-on-one basis. Typically, homes start at the foundation if they don't have prior intersection with the program. But we certainly don't want to eliminate the fact that there are places out there that are innovative without having gone through PEAK. This is the incentive structure associated with the program. You can see it's escalating per diem. So at the more novice levels, it's a lower per diem. This is per Medicaid resident per day. You can kind of see the examples here to the side and how much revenue that might generate. Then through level 8, which is $3 per Medicaid resident per day. So you can see a foundation home goes into the program doing a year of structured education and training that builds up to being ready to move into the implementation stages, and they get incentive dollars for participating in those things and producing the action plan. And then when homes are at that working stage, they're at the levels 1 through 5. And actively implementing practices around the 12 cores. And then in the upper levels, it is about sustaining practices and mentoring others. This whole caveat here just talks about if a home receives a G level deficiency or higher, it does impact all incentives, including PEAK. And depending on what the level of severity is and the correction processes, it can be 100% reduction in incentive or to 50% reduction. It just really depends. And that's where KDADS comes in and helps coach homes through that piece of it. The thing that I like to tell homes though, is that if your goal is person-centered care and regardless of what your survey outcome is, because sometimes there are situations that are one-offs that are kind of, they're those situations that are unforeseen and unintended, and they may result in this, but our goal is still, we want to stick with person-centered care. You're not kicked out of the program because you got the deficiency. You can continue with the program and continue advancing at the rate that you're advancing. And when the survey penalty is gone from your record, you can come in at the level you earned. So let's say you started at level 1, you got the deficiency, and by the time it was released, you popped up to level 3 because you worked on several cores. You come in at level 3, you don't have to go back down. Now, sometimes the survey challenge is so great that it is revealing big troubles in your home for whatever reason, and you need all hands on deck to really get back in compliance. And you might be at the foundation level when that happens. That may be a time where you as an organization decide to step back and say, we've got to get in compliance and then we'll get back in the program. But you're not necessarily losing ground in it. You're tackling what you need to get into compliance, and then you're going to pick a more opportune time to get in. That's really a judgment call on leadership and the team at the home. And we just help coach teams through that as they're trying to make decisions that are best for them. So I wanted to talk a little bit about the levels and what's expected at those levels. So the foundation is that year of structured education and training. And if you know about the Eden alternative and Eden Homes, Bill Thomas would call this work warming the soil, because you're getting teams ready and educated for change. And so we use the approaches that really help get those teams aligned and all invested and engaged in the process of what they're going to decide to work on and do as they move into the implementation stage. And so the requirements here are really to participate in these activities and produce an action plan at the end. And we coach and require at different points in time that the team participates, not just one person or not just positional leadership, but that team and direct care staff are involved in the process. And then at level 1, at levels 1 through 5, this is where the actual work of implementation comes in. And so homes at these levels select 2 to 4 cores, and they write an action plan on those things and implement them throughout the year. And they get evaluated on an annual basis, either by a virtual Zoom meeting or an on-site visit, depending on their selection. We do a random selection of about 20% of homes that are in that level. So it's anywhere from 10 to 15 homes a year. We've done up to 20 when we had a really large number of homes in the program. We had up to 200 homes in the program at one time. So that was more homes that were visited, but more homes in the program as well. So there are lunch and learns that we do for education and training. There are lots of resources on the website, and there's opportunities for one-on-one coaching and consulting for homes at these levels. And then at the upper levels, this is where, I should go back to this and say that at levels 1 through 5, if they have passed a core, we all know that we can accomplish something, and then, you start working on the next thing, and sometimes practices slide, or you have turnover in the home and practices kind of backslide some. So it's important that sustaining of practices is integrated in that. And so all cores, even those that have been passed, are reevaluated every 2 years to spot check that they are still in place. And then, so levels 6 through 8 work on maintaining practices at the 90% level, which means that across all the practices, there are 85 individual practices, that 90% of those practices are being sustained to maintain that upper level and mentor other homes. And so these homes get evaluated annually or biannually, depending on where they're at in the process. So I want to talk a little bit about benefits beyond improving life for residents and quality of life, and the inherent good of providing person-centered care, but there are some other benefits, and they're good for business. One of those is workforce. So turnover, a home that has 45% turnover and about 60 beds, that's costing that organization about $250,000 a year. Turnover is about 33% of the annual wage of a person's position. So every person that you've lost over turnover, you can calculate 33% of their wage over the year. That's what gets us to that $250,000. So just by reducing turnover by 15%, you're gaining $75,000 to your bottom line, approximately. And what we found in our homes that have advanced through the PEAK program, from the lower levels to the upper levels, is that their turnover has reduced or been improved along the way. And so they're seeing some of these savings. Then on the other side, our other business metric is census and the revenue generated by census. And so when we're looking at some of our upper level homes, they saw an increase of about 15% in their average census for the year. And that 15% increase led to a 22% increase in revenue, which generated over $500,000 for the year. That's a big deal. One of the other things we've heard by more than a couple of those homes is that they weren't the primary provider that the hospitals were sending people to, which really helps you get more people if you're the preferred provider. It was word of mouth. It was people who had good experiences sharing that with other people and encouraging them to come. And so it wasn't even higher marketing dollars or getting on the ground recruiting. It was word of mouth and people coming to their door. And then the final is quality and compliance. So research says, specifically on Peak Homes, that there was a 42% reduction in significant depressive symptoms in the upper level homes on quality measures. There's a 34% decline in catheter use and a 38% fewer pressure ulcer incidents in the upper level homes. And so these are all really important indicators that are good for business. So we encourage you to spread the word and to have people enroll. The opportunity is open until April 30th, so it's coming up quick. You can still get in on the program. My voice is starting to to get weaker. So this is also in the chat if you want to link directly to that. But I will open it up for questions. Yeah. Share the other one. I see a few Peak Homes on the call. If there's anybody who would like to share how the program has impacted you, I would welcome you to share with the group. Well, we are done with all of our formal presenting and we will be here to answer your questions. But if you don't have any questions, you're welcome to leave at any time. Appreciate you coming today. Yeah, so we talked earlier about the Person-Centered Care Conference. It's annual. This year is our 25th anniversary for Peak, and the date of the conference is October 23rd, and it's here in Manhattan. There'll be more information coming out about it. You can click on our website to get, current updates on it, or it'll be going out through email blasts through KDADS and us as well. See, I should have looked at my calendar before I said it. Numbers are not my thing. October the 22nd is the Person Centered Care Conference. We reserved both dates, but we went with the 22nd. So thanks, Jamie.
When do we typically send out the information about that again? Maybe you could speak to that.
Yeah, around in August, around that time frame is when we get the full like program details and registration opens and all that. Yes.
And the theme this year, in case you're joining here, is it is our 25th anniversary of Peak. So the theme that was decided on with the advisory board is Shining Bright at 25, Illuminating the Future of Care. So we'll really be leaning into the silver theme of it all to go along with our 25th anniversary.
Silver and light.
And light.
Yes. And if you are really good at these sorts of things and want to volunteer, we welcome you to put your hand in the pile to to be a part of it.
We have a very diverse set of people part of our Peak advisory team. And it is very helpful having so many different people from different backgrounds. We've got a couple of ombudsmen, and we've got a MCO, someone who works with one of the MCOs, and a lot of different people from a lot of different areas of homes from the oh, I just forgot the word for the things that you do, like the crafting and the games, activities, from the activities managers to administrators, to direct care staff. I think even we've got a little bit of everyone coming together and talking monthly on how we can make this how we can help this program grow and flourish. And we get some really good conversations, and it's a really good team. So that is in the chat too, how to be a part of that team. We've already got one person come through already. So
Great.
we will be looking at that team in July too, again, to see, that's when the natural cycle will happen. So good, 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 good.
The other thing about the conference is that we really like to try to involve residents in different ways, and that has evolved in kind of how that plays out each year. But if you have interest in engaging residents in the conference, we encourage that. We have physical presence of residents at the conference, but we've also had residents write notes about their favorite caregiver and some reasons why they're their favorite caregivers and different things like that. And so if you have ideas around that, we're always willing to take them. Those creative thoughts. I think one of the real hearts of person-centered care is not entertaining residents or doing to residents, but to engaging residents and to really having residents direct lives and take an active part and role in things. And so that's something we like to try to model through this too. And so that really just shows the heart of the work. So
Last year at our conference, we had we had our Peak ambassadors that came from different homes, and I just enjoyed listening to them. I got tickled pink when they got excited over the bags, because they each got a conference bag, and they were sitting there chatting about how they're going to be great to hold their books in. And I'm like, yes, I picked out those bags. I'm glad someone's happy with them. But it was really sweet and warming and whatnot. Just I enjoy chatting with the peoples. So I loved having our peak ambassadors last year, and they're lovely.
A fun story about that is, our work brings us into homes and we have multiple projects going on. So in association with one of our other projects, one of the ambassadors had been at the conference, and then one of our team members went in to do an interview and they recognized her right away. You were at that conference I was at. And she says, you're famous, you are famous, you were up in front of everybody. And he just glinted, just smiled from the inside that she would recognize him. So it was fun. The other thing I might mention is that about annually, COVID is kind of an exception to this, but we do get feedback from peak participants on things that work well with the program, things that are challenging about the program. And we do that through a peak experience survey that goes out to homes, and that will be going out to homes pretty soon as a part of the yearly cycle. And we process that information, and the peak advisory group, if you weren't on earlier, there is a peak advisory group that that you can be a part of, but they help provide suggestions or recommendations to KDADS and K-State about ways that the program could be improved, our own quality improvement process. And so that peak experience survey gives us data to help us think about, from a provider's perspective, what things can help improve the program. So just wanted to let you know how we do our own quality improvement, how we try to get feedback from homes, and who's a part of looking at that or thinking about what to do with that information. We are winding down on time, so if you have questions, now's your time.